Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Influencing Patient Behavior, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by YourCareUniverse. Just a little housekeeping before we get started. My name is Anthony Guerra. I am the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We've also got a simultaneous tweet chat going on, hosted by our Director of Social Media and Managing Editor, Kate Gamble. You can open up a browser or go on your phone and start tweeting. Just use the hashtag HSCIOinfluence, and they'll all be collected there. And you can see in your media viewer all the tweets as they go up today. So if you just want to view, you can stay in WebEx, but if you want to participate in the tweet chat, you can do that if you use our hashtag. We encourage you to ask questions today, which you can do by typing them into the lower right-hand corner of your screen in the Q&A panel. Leave the default set to all panelists, and I will get those in front of our panelists later in the program, but go ahead and type them in as they occur to you. And you can download the deck by using the URL on your screen. We've got a shortened URL at the bottom of each slide, and we'll also send that out in the chat box. And we are recording today's event. We'll get our archive up on YouTube within 2 business days, if not sooner, and you'll get an email when the archive is ready. Excuse me. Just so you see how we're going to spend our time today, we're going to go 30 to 35 minutes with our panel discussion featuring Chuck Fennell, CIO at St. Joseph's Hospital Health Center, Howard Landa, CMIO at Almeda Health System, and Blair Baker, VP of Product Strategy at YourCareUniverse. So without further delay, we're going to jump right into our Q&A. Why don't we get an overview of everyone's organization? We'll start with Chuck.
Thank you, Anthony. St. Joseph's Health, we're located in Syracuse, New York. We serve about a 17-county region in central and northern New York, anchored by St. Joseph's Hospital Health Center, which is a 451-bed acute hospital with a complement of outpatient ambulatory surgery centers, urgent care, and the usual mix of other ambulatory services. Like many organizations, we have a large multi-specialty physician enterprise that extends out into the community through our clinically integrated network, and it's the clinically integrated network that's driving a lot of our population health initiatives. So we're participants in the Medicare MSSP. We have a risk value-based agreement with our largest commercial payer in the region, as well as a participant in the Medicare Model 2 bundled payment. And then just quickly from a IT perspective, we are an Epic organization. We went live across acute and ambulatory in May of 2014, and through growth have acquired since then a complement of other EHRs and billing systems. Excellent. Dr. Landa?
Yeah, so Almeda Health System is the safety net health system for Alameda County, which is the kind that Oakland is in. We're Oakland's trauma center. We're 5 hospitals. Our main hospital is our trauma center, acute care facility. We were, when I started, 3 hospitals. We had a 100-bed psych hospital and then a long-term care and acute rehab hospital. And over the last couple of years, we've acquired 2 other hospitals within the county to provide more community-type, lower acuity services. So currently at 5 hospitals. When I joined, we were in the 3 hospitals went on a journey to put in Siemens Sorian with the promise that they were going to roll out emergency room software and ambulatory software and other entities. Unfortunately, that did not happen. So we are Siemens Sorian in 3 hospitals. We have 2 hospitals we've acquired, which are 2 different versions of Meditech. And then we have next-gen and ambulatory. So it's an incredible hodgepodge that we are now trying to take a step back and realign to a single system and looking at a couple of large vendors out there to replace everything. Our patient population is interesting. You know, we serve the indigent. Many of our patients have no insurance despite Obamacare. Many are not very illegal aliens, if that's the politically correct term. I keep getting mixed up on that. But it's a multilingual population, multi-social population, so a challenge from that perspective that not all healthcare organizations need to manage.
Very good. Blair, you want to talk a little bit about YourCareUniverse? Blair, go ahead.
Great, thanks. YourCareUniverse, we are part of MedHost, which is been around for about 30 years, servicing over 1,100 hospitals. And YourCareUniverse itself is focused on 340-bed hospitals by providing cloud-based solutions for allowing the management of patients digitally and supporting the consumerism within healthcare. And our platform includes interface engines, private HIE for our customers. We're agnostic to any EHR or EMR, so we're untethered. We have a patient portal that is the second largest footprint as far as market penetration within the United States. That also comes with a Meaningful Use 2 certified app. And we also have a multifaceted analytics suite. And we're providing those analytics and a marketing service that sits on top of it, along with many tools that enable the hospitals and health systems to influence their consumers and patients throughout the healthcare continuum.
Very good, very good. All right, Chuck, let's go back to you. Why don't you give us an overview of your top IT initiatives for this year?
Top IT initiatives. I'd say that the usual lineup from a provider perspective, security and integrity of the information and systems that we provide is certainly first and foremost, particularly in the current environment and some of the headlines that have been created. I think supporting various population health initiatives, both from an analytics perspective in a heterogeneous environment, as well as the care management needs is what I would say is a close second. And then really coming off the heels of a large enterprise system implementation, I'll say demonstrating the value of IT to the organization and knowing that there's no shortage of good things to spend money on, and that the cost of and investments within IT have increased over the years. How do we really demonstrate the value of those investments? So those are really, if I had to sum it up, the three things that we're focused on this year.
Great. Dr. Landa?
Anthony, it really is Howard. It's fine. Certainly the biggest thing that we're looking at, as I said, is an EHR replacement strategy. So we're doing a lot of work and looking at exactly what we have and where we need to get to, doing the change management for that, and an evaluation to make a selection. Aligned with that is, where's the money going to come from? Because these systems do not have a huge return on investment for the actual hard dollar ROI. So in talking to the finance department, their statement is, well, you have 5 EHRs, so why do you want another one? And the understanding of replacing that to really align a single EHR strategy to support patient care is a struggle. So I think those two are the top priorities. At the same time, we have so many projects that are actively running to support the disparate systems that we have. Trying to prioritize all the requests in a way that makes sense relative to our final goal is something that a lot of time and energy is invested in. I wouldn't call it wasted, but at the end of the day, it's there's no real value add for that. And the question I keep asking is, what are we going to stop doing? Because I would love it if someone would come to my office and say, you know what, I've got a terrible idea I want to present to you. Because they're all good ideas. It's just a question of the prioritization.
Right. Very good. Blair?
Our focus is around supporting the continuum of care of the patient, and that includes being outside of the 4 walls of the hospital. So how do we enable our health systems to be able to effectively manage the movement of the patient from all their post-acute care, whether that be from any kind of step-down facility, post-service to, the physician-to-physician movement of patients from general to specialties. We're going to focus on interoperability, and not just within our own systems, but more importantly with other EHRs and EMRs. We have a high concentrated focus on the consumer of healthcare and the tools to help influence those consumers, along with driving the desired population that the healthcare desires into their health system, and then finally a digital approach to really bridging the relationship between the clinician and the patient when they're managing their chronic diseases.
Very good. Let's start out with Howard. Howard, interoperability is huge. A lot of organizations are talking about it, working on it. A lot of officials are looking at it. In your opinion, what should IT leaders focus on in the next 1 to 3 years to achieve system interoperability or make significant progress?
You know, I think the single biggest thing, and this is what a lot of the focus has been on, is at getting information ubiquitously available to clinicians. You know, one of the greatest things about an EHR is the fact that we're no longer losing charge. We're not waiting for charge. We're getting that information where it needs to be. But that last bit that says, okay, it's in that system over there, but it's not in my system. And yes, I could get it, but it's too hard to get, and I'd rather talk to the patient. And that's within our own system. You know, with multiple EHRs, getting people to actually go into separate systems to aggregate that data mentally is a major challenge. So I think getting those systems to talking to one another, getting good information, not just tons of raw data, transition to the point where I've got a good user interface that pulls all that data together that I can look at and say, here's what's going on with this particular patient. So we see a lot of things about FHIR and integrating. I get literally every week someone telling me that they want to develop apps for me. I'm like, we're a long way from that. We need to get that basic information delivered in a usable and impactful way before we can start expanding beyond that. So I think that's the single biggest part we need to focus on. And fortunately, with all the attention the industry has put on this, I think that's what's really being driven in the short run. So that's a great thing.
Chuck, your thoughts on interoperability?
Yeah, I agree with Howard. You know, in the time frame, I think is important that we're talking about here. I mean, over the course of the next 1 to 3 years, I mean, what is reasonable from an interoperability standpoint? And I think advancing or continuing the support of safe transitions in care between acute and ambulatory, ambulatory and acute, or ambulatory to ambulatory. And I think, you know, we've made some strides in that, but I think there's a lot of other workflows and a lot of other environments in which we don't have safe transitions in care, whether it be behavioral health environments or labor and delivery or OB services. So I think if I were looking for something or to advance something in the short term, it would be continuing to make strides along transitions in care. And then beyond that, obviously, you know, bringing in more discrete data to support population health and care plans and all the other needs.
All the other good stuff. Yeah. And post-acute care and rehabilitation, of course, big elements too, right?
Yeah, great point. Yep.
Anthony,
Blair? Go ahead. Go ahead, Howard.
Part, I think the medication management piece, and to kind of strike out on the the transition of care topic, bringing that medication management piece into the interoperability world and looking at it that way, I think is something that we really need to start doing. It's looked at predominantly as, the physician or the clinician does something to reconcile medications, but it's gotten so complex with so many different data sources. We need to start incorporating that as as an important piece, almost called out, around interoperability.
And are you talking about medication reconciliation? Is that also what you mean?
Well, medication reconciliation is one part of it, but just the management of medications, especially in the inpatient world, it's easier. But when we start talking about transitions of care and the ability to take someone who has been prescribed 3 or 4 different medications of the same type by 3 or 4 different people, and the patient is deciding what they're doing and knowing how to cancel those prescriptions, how to get them out of the system, how to identify what the patient is actually taking versus what the record says, a lot of energy is going into that. And if we can get that data, because the data's out there. I mean, patients are getting those medications from specific entities at specific intervals. So applying some intelligence to that might really facilitate the whole medication reconciliation process and identifying what is this patient on today? Because that's the critical question you have when you're seeing someone who's having a problem.
Right. I mean, it's incredibly complex, right? I mean, the patient comes in with a condition, and they're usually on certain medications. Based on what's being found in the hospital, what do they need to continue to get? Based on what might need to be done to them in the hospital, what do we need to do with their medications? What new medications do they need while they're in the hospital, perhaps preparing them for some sort of procedure? And then leaving the hospital or going to the next phase of care, what old medications, and then everything can be adjusted, not just starting and stopping, but adjustments, and who's looking at all this. So I'm sure I butchered that whole thing because I'm no clinician, but Howard, go ahead and just make me sound smart. Did I make sense there?
No, absolutely. I mean, you know, and the transition of care coming into the hospital and going home is probably the easiest because you've got the most clinicians looking at it. You're really evaluating everything. You've got a real tight look of what is going on clinically and physiologically with the patient. But when they come to your office, having seen 4 other people who have all made changes to their medication record in their offices, and those prescriptions have gone out and they have filled or not filled based on their insurance, and changes have been made because of payers, or they chose not to fill something because it was too expensive, or you prescribed it twice a day and they're taking it once a day because it's cheaper that way. All those pieces come in, and trying to make sense of what's really going on and try to figure out how to get to that next step and say, you know, we can tweak this a little bit and make you a lot better, but we really need to understand where you are.
Blair, you want to talk a little bit about this?
I would, and you know, Dr. Landa brought up some great points, and really where that ends up, and that's to us to enable what the health systems are looking to accomplish. And so on the vendor side, it's really up to us to be able to enable that sharing of that clinical information amongst the EMRs, and even going out as far as the patient data. Or, you know, in fact, right now we're working with another ambulatory vendor where in the past we had been competitors, but we've recognized to make our health care providers successful that we need to be able to share that clinical information using standard technology that exists today, so that the physician will be able to see that complete record of the patient regardless of their care setting, whether they're in the acute setting or the ambulatory. And that also carries over to the patient. In their patient portals, we need to be able to consolidate that clinical information so the patient has one digital filing cabinet of their health record, and not have to go to multiple patient portals to be able to get that. We also have the tools that we're developing to help build those integrations where maybe some of the standard transactions don't do today. And then also the ability for patients to access their own and enter in self-generated information, and for us to be able to provide that visibility to the healthcare provider as well. So, you know, really the execution comes to us on the EMR EHR side.
Howard, can you touch on that idea of patient-generated data as a physician, your thoughts on the value of it, the limitations of the value of it, and how it could be integrated to the benefit of the clinicians on the spot?
Yeah, this is a great topic and one that physicians really struggle with. If I could present to the patient a form that they could fill out that would get all of my basic coding information into my EHR, that's something that is really easy to convince physicians is a great thing because it's taking work off their plate and it's getting good data into the system. When you get beyond that, you start talking about the Internet of Things and pulling data in from how many steps to what are my blood sugars to how, you know, where am I in the world, what are my blood pressures, how much do I weigh. You know, all of that data is important in looking at a patient at a global perspective, but in a brief ambulatory encounter, it's not something that clinicians have the ability right now to manage. Patients will walk in with, you know, here's an Excel spreadsheet of all my blood sugars for the past year. How am I doing? You know, that is not a tool that any physician is going to use to accurately determine what's going on with the patient. I'm much more likely to ask, well, you know, when your blood sugars are low to you, what has been going on? What do you do about it? When they're high, what situations have you been in? One of the problems with a lot of the patient-entered data is, again, problem, it is discrete. It's a discrete number, it's a weight, it's a blood sugar, it's a step number. That is really not very useful to a clinician. I need the context. I need to know what's going on And I think in order to make that kind of data useful to clinicians, we need some piece of middleware that will aggregate structured data, bring in some of the context that we can get from the patient, either in a question and answer or a natural language processing way, and then create some kind of a delivery mechanism to the physician that says, this is what's going on around this problem because of the data I've aggregated. And I can drill into it, but as it's delivered right now with, just columns of numbers, it really is not very useful. And it's a real struggle because the patients spend a lot of time and energy putting this together and then are frustrated when the physicians would rather put it aside and talk to them about what's going on. And they really don't understand. So it's a huge opportunity, but we have a ways to go before we can actually make it usable to the clinician.
A ways to go. Very good. All right, let's start with Chuck on this question. What are you hearing from providers in terms of how they want to communicate with patients? So as we're talking about your physicians, how do they want to communicate with their patients?
Yeah, I think Howard touched on some of that, right? I think it runs the gamut. In terms of some of the new communication tools that are available out there in the portals and the way that patients can interact and expect to interact with their providers, I think that presents some new challenges to providers and the way they accept and the way they process some of that information. I think that the more interesting side of this particular question may be, what are the expectations of the patients and what are they expecting on behalf of their providers and the conveniences that they see in other industries, and how do we adapt on the provider side to be able to respond to those growing needs?
Watch this. Look at that. See? Wow. That was another one of our questions, so well done. Okay, Howard, you want to touch on that? You can touch on both. What providers want and what patients want.
So you talk to providers, intellectually they understand this and they want this kind of information and this kind of relationship. They really want that. They want to have a multifaceted relationship with their patients. They want to be able to have their visit in the office. They want to know what's going on in between. But they personally don't have the time or the tools to manage it. So I think the single biggest thing I hear from physicians about interacting with the patient through technology is, who is the middle person that sees I only want to see what I need to see. I don't want to see prescription refills and simple questions. I don't want to become the nurse on the telephone electronically. So as we incorporate the technology, we need to make sure there's enough human intelligence in the loop to allocate the information and the requests to people who are working at the top of their licensure. So I think that's the single biggest thing I hear from the physicians about their concerns. From the patients, our patient population is a very challenging one. The social determinants of health are a huge issue for us: homelessness, nutritional problems, all those things. And layer on top of that, that only a third of our patients are actually fluent in English. So the majority are speaking some language that is not the doctor's primary language, and we're not talking about the 2 or 3 basic common languages, but we have a video interpretation service that we use that covers 140 different languages. This is a huge challenge technology. People may have a vendor portal in Spanish or in a particular language, but no one's going to have that kind of depth and breadth. So you have to incorporate somebody else into the loop. There's some kind of a health coach, there's a family member, there's a community leader, a religious leader. Somebody else has to get involved to help, because the patient probably doesn't have the resources, at least in our population, to interact directly. So we need to account for all of those pieces in the development of a digital relationship with our patients. But even the homeless, even the indigent, the vast majority of them do have a smartphone, because that really is their connection with the rest of the world. So it's a huge opportunity that we need to leverage, that most of the portals and things are still more geared around having a real computer experience. We need to get it to the point where it fits on a small screen better.
Chuck, let me just go back to you real quick. I want to touch on a phrase that Howard just used that I really liked. We need to make sure clinicians are working at the top of their licensure. That sounds like a really good mantra for CIOs to live by. and a good yardstick to make sure that they're putting out technology that is empowering folks. Does that sound right?
Agree completely, right? And extending beyond, the physicians in the practice, but extending to the entire clinical and support staff.
Right.
So, and as these requests and as we begin to interact more and more with the patients electronically, setting up those processes and those functions within the office, I think are very, very important. And Howard touched on something in the local market in his area, dealing with how do we abstract information, health information on the patient, and it reminded me of a pilot program that we have in Syracuse with one of the inner city clinics that we have recently expanded, but it's literally in the parking lot of the only full service grocery store in the city. And it partnered with that grocery store on a Shoppers Club card for patients that are seen at that clinic that tracks that patient's purchasing habits, and then we abstract the food and beverages and commodities that patient purchases at that grocery store, and provides that information in an abstracted form back to the provider to be able to coach that patient or have the appropriate clinical support staff coach that patient on some of the healthy eating habits or the unhealthy eating habits that patient may be using.
Blair, do you want to jump in here on anything you've heard? The main two questions that we started with were providers' expectations of communicating with patients, and then we touched on patients' expectations of their preferred communication methods. We went into some other areas. So wherever you'd like to tackle.
Sure, and both Chuck and Howard bring up some great points, and we spend a lot of time in this area. Our providers are definitely asking us, they want to be able to have that digital relationship with their patients, and the patients are expecting it. It is now, as Howard said, they want that mobile experience, especially to the mobile device. I mean, we're seeing that 78% of patients are now wanting to access their medical information through a mobile device. And I can sit here and look at the analytics of my tool, throughout the day as people are accessing it. And it's, from a patient, I would say it's in the 90+ percentile, at least of ours, who are coming in either through a tablet or through a mobile device. But it is a little bit of a challenge because the provider themselves or the physician is going to have a hard time, keeping up with appointment reminders, the messaging, the emails getting from the patients that they're sending, the prescription refills and so forth. I mean, in our tools, we've built different kind of roles to help segment that out so that there's support staff to the physician to account for that, but it's the expectation now of patients for that. And Howard brought up some really good points about the language. And, in our patient portal, we have multiple languages capability in there as well. And what we're finding is that it's not highly utilized, but yet what we're finding is it's actually a family member of the patient, often a child, who speaks English, who's in there interpreting and navigating on behalf of that patient. So it's very interesting, but from a technology standpoint, we're having to be able to provide multiple pathways for that patient's information or request to go to the appropriate staff members of the physician, and also where it is most appropriate to the physician.
Blair makes a great observation, bringing the family members in, and even children. In the office, we're not allowed, allegedly, to work with family members as translators. We really need to bring someone else who is a certified translator in. Yet, in this kind of experience, you can have a 7- or 8-year-old who's sitting there typing and putting in data, and that adds a whole new level of ambiguity because they don't want to tell, one, they don't want to tell their child certain things, and two, the child really doesn't understand, but they're doing the translation. And the other multilingual problem is the patients want to be able to communicate in their own language. One thing to say, the portal has tools and menus that are in their native language, but someone is still forced to communicate with the provider in a language the provider understands. We're not going to put an electronic translator in yet between the 2 points, and having someone go and translate all of this from a written text out of context, it gets really difficult. You're putting layers and layers of ambiguity there and really raising the risk of errors.
Very good. Very good. All right, Chuck, let's go with you on this one. How do technology needs of chronically ill patients differ from comparatively healthy patients?
We touched on some of this, and certainly I think Howard as a provider may be able to weigh in terms of what is relevant, but I think from a chronically ill perspective, there is a lot more biosocial data that may be important in terms of what's happening to that patient outside of the 20 minutes they spend with a provider in the office, and how do we interpret that information when they are symptomatic, which is probably even more relevant, as they present to the provider's office. So I think it's really how do we collect the environmental data through wearables and some of the other technologies that patients are now employing, and integrate that in with their chronic disease management.
Howard?
It's a fascinating question, and it really breaks into three parts. And one is what is the chronically ill support that we can provide with technology? What is the acutely ill technology? So the person who comes in with an acute illness that is not a chronically ill patient, and maybe isn't of the severity of the chronically ill, but they're just coming in for, a routine visit to deal with a flu, a urinary tract infection, whatever it is. And then you've got that whole morass of data that we're trying to work through about how do we keep people healthy, which isn't health care, but it's more around health. So that is, those three areas that we need to address individually. The real chronically ill tend to be older, tend to be the ones who really don't have the technological capabilities to interact with us in ways that the millennials do. So again, they need that extra person. There is more structured data available, and it's more usable. In this group, it isn't the number of steps, but it's actually their blood glucoses or their weight on a daily basis because they have congestive heart failure. So that data is a little more usable. And again, bringing someone in to function between the physician and the patient, so some kind of a health coach, whether it's hospital, whether it's clinic-based or community-based, who can say, okay, you know what, you're 2 pounds up, but it was the Super Bowl and that big bowl of chips and all the beer, maybe that's the cause of it. Protocol says you can take 1 extra pill of this, let's see what happens with that before we bring you in to see the physician. Intervening earlier, before the patient actually even recognizes that they're getting ill, and preventing that visit or that hospitalization is where I think we can really impact the chronically ill. Going from 4 hospitalizations a year to 3 is a huge thing, both financially and for the patient. These patients are in the healthcare system all the time. Anything we can do that keeps them in their homes feeling reasonably well is a major win.
Blair, you want to touch on that?
Yes, this is something that I've been deeply involved in really over the last 12 months, and that is it goes to managing the chronically ill patients. For the regular healthy patients, they have more of an episodic experience with their providers and also with the digital capabilities. They may check in on some results of a lab work and so forth, and then they're done. But really, from the chronically ill, this is just a challenge for our healthcare providers, and the fact that they're building wellness centers and all the right educational programs to really help these patients manage their chronic disease, but often that requires a patient to have to visit those facilities, to get into a car and come, and then depending on the setting of their organization, that could be a 5-minute ride, it could be a 10-minute ride, it could be a 50-mile drive in, and that's a challenge to get that participation. I mean, we see, I've been working with a diabetes program where 25% of the patients who are choosing to participate in the program, of the 100% that were referred, only 20% of those actually complete the program, and it's a 12-week program. So really what they need is that digital experience that's going to allow for the patient who, especially for diabetes, which is a non-systematic disease, or symptomatic disease for the most part, is to be able to make that behavior modification of their lifestyle. And so we've provided an app on the phone that allows them to track and trend their measures and their goals that are defined by their clinical coach. on the other side who's able to then monitor the entries and the moods of the patient and know then when to engage the patient or to poke them digitally or when to send them the attaboys. And then also we've created support groups digitally for the patient based on, they'll be moved through those support groups based on where they are in their condition. But most importantly, it's how do we create that digital approach? Because like most people now, we have a relationship with most things. Like we have a relationship with our weather through an app, with our news through an app, but our healthcare through an app, and especially if it's a chronic disease, that's going to allow that along with the integration of the the Fitbit devices and any kind of Bluetooth devices of their healthcare, but really to pull all of it together so the patient has a tool they can manage their behavior changes, and then the clinical view to come in and to engage when necessary.
I just want to emphasize what Blair said. It's all about the behavioral piece. We can only do just so much. We can recommend a pill, we can perform surgery, but for many of these patients, it's changing the way they run their lives and changing that behavior. And once we identify that something needs to be done, getting people to change is something that we're really bad at and people are really bad at. And if we can provide tools that actually help them through gamification or whatever mechanism we can come up with that actually gets that behavioral change, that's when you're going to start seeing improvement, reduction in costs, and improvement in the in their quality of life and their health.
And Howard, how often does change in behavior come down to financial incentives?
Well, for physicians, it seems to work pretty well. For patients, probably not quite as much. I wasn't sure what the direction you wanted to go there, but I don't think it's financial incentives. I mean, financial incentives, certainly in my population especially, you'll get people to do all kinds of crazy things for a little bit, but that's not changing behavior. That's just getting them to do one thing at one time, but actually getting to recognize the health benefits and start seeing them. And again, a lot of it is appealing to the emotional side of it. Intellectually, they know they shouldn't eat the potato chips and they shouldn't drink the beer while they're watching the game, but the reality of it is they're going to do it. So how do we moderate it? How do we get them to start practicing, nibble around the edges, getting them to do a little better behaviorally, and then showing them if they do this, hey, this Super Bowl, you didn't have to get hospitalized after. First time in 4 years. Isn't that great?
Okay. All right, very good. I want to take an audience question now and remind our folks that if you want to send in a question, now's a good time. Type it in the Q&A box, leave the default set to all panelists. It goes back to interoperability. Chuck, let's start with you. Who do you think should be the driver of interoperability, government, private sector, or both? How do you see it being achieved? FHIR is the new kid on the block, but is very limited. How do you see the community moving forward to encompass more use cases?
Good question, right? I think we've gotten where we are, which is, I'll say, not very impressive in terms of other industries, but very impressive over the last 5 years or so from a healthcare perspective, primarily through government intervention and driving and forcing vendors to be compliant at least with some basic interoperability standards. Definition of those standards and understanding the use cases and expanding those standards to support some of those use cases, I think should be driven from an industry perspective. And how do we come together as an industry, I think is a larger question there. I think if needed, continued incentives or penalties on behalf of the government, the carrot and the stick, I think will help. But I think it's got to be an industry-driven, use case-driven, clinical-driven definition of what needs to be done.
Howard, do you want to touch on that?
Yeah, I think it was well said. I think this is a multi-pronged approach. I think there does need some government encouragement, however we want to define encouragement for interoperability. I think it's already there for sure, and I think you're seeing the vendors respond to it. So I think that's one prong. The other one, though, is I would really not carrots and sticks work, and meaningful use is a great example of that, but they're limited. And the thing that isn't as limited is the real volume to value transition that CMS and others are trying to push. So if you don't need to do another test, if you don't need to spend the money to do another CT that was done 2 days ago because you can't get the result, that's a huge savings and the reduction in risk and injury to the patient from the radiation. So the opportunity to basically say we're going to pay for quality, for value, for convenience, for improved care and improved outcomes will turn around and drive the need to make data ubiquitous across the whole continuum. So from a government perspective, I would love to see them really pushing this in intelligent ways. We have lots of quality initiatives and payment for quality programs out there, but they're really all focused around proxies for quality. You know, your hemoglobin A1C in aggregate is lower than somebody else's. You have less admissions for a given disease. But taking a step back is, you know, if I spend all this money on program A, which reduces admission for a given diagnosis, but I'm not paying attention to other conditions and my admission rate goes up for those, I haven't actually gained in the long run. So, you know, the entire paradigm of, you know, a care management program that basically says we're going to pay for the overall quality. And, you know, a lot of the organizations, you know, I worked for Kaiser for many years, so a managed care organization which, you know, is financially responsible for all of it, not just getting more money for a single action, produces an environment where you need to exchange information, you need to make these systems interoperable and easy to use, you need to deliver the information to the clinician so they can, in an impactful and actionable way, and then you'll start getting those results. So I think that's the government's role in this, and the vendors have started to recognize that they need to play well together because it's the right thing to do for the patients and for clinicians who are providing care.
Very good. Blair?
You know, I'll start with the government side, and like both Chuck and Howard, I do agree that the government creates some great encouragement and the excitement behind the need for interoperability. However, I've seen over the years that it's just really not helpful unless there's enforcement penalties. So it's great, gets a lot of excitement, but it really doesn't solve the problem because there's not a whole lot of funding to enforce the usage of this and apply penalties where appropriate. But I'll see the private sector is really starting to drive the interoperability needs. In fact, you know, we've got really two main players in the industry who have what we'll call a closed system that provides all the patient data, for the most part, that's needed for both the physicians and the hospital. And for those that are on the outside, if they don't figure out the interoperability and to be able to share that data seamlessly amongst one another, they won't survive. They'll be replaced. And so that's really starting to drive the market and the need for the EMRs and the HISs to kind of break down those competitive walls, do what's right for our customers and for our healthcare community by being interoperable and really surviving the you know, where the market is going. So, you know, I do see that the private sector is doing that. Regarding fire, I think it's a great step, although it is not 100% standard. But I do think that the competitive landscape now, more than ever, is going to demand interoperability amongst the vendors.
Very good. This seems like a good audience question for you, Howard. How do you adjust behavior for those who may be low income and live in a food desert?
Whoever can answer, I've got a job opportunity for them. You know, the social determinants of health are a huge issue for us, and we struggle with them every day. We are compensated by the county, by Medicaid, by other organizations to provide care for those who are underinsured or uninsured, and these are the people who fall into that group where social determinants of health are a big issue for them. But we're not charged with providing housing, providing food, doing these things. There's other portions of the government that is charged with, you know, trying to provide for this. We are trying to work with those other agencies and to optimize both the health care delivery that we can provide and the improvements in health that they can provide. But, you know, it's a resource limitation, and it's an interesting question that we struggle with. So we haven't really gone into the whole big data project of looking at where the better food stores are and, you know, how we can push people to those locations. It just hasn't been part of our core competency and our core mission. I think you'll see some of that evolve over time as we get to a more and more, again, as we go from volume to value, and we're all responsible for the overall health of the population. I think you'll see more investment in those areas, but I think it's an area ripe for innovation.
Very good. Well, I think we're going to try and sneak in one more quick one. So Chuck, let's tackle this one quickly. Maintaining relationships with your patients outside of the four walls. If there's anything in addition to discussing the idea of communicating with patients that we had before.
I don't think, Anthony, anything more. I'll say other than the traditional communication methodologies, the newsletters and social media engagement, and then, obviously through the portals and different care management platforms that exist. So I think we covered on most of those topics in terms of.
Okay.
Unless somebody else has a thought on that.
Howard, anything more you want?
At least what we're experiencing here. Sorry.
Okay.
I think we've touched on a lot of different areas. The one thing that I'm really pushing in my organization is that we really need to have resources that are dedicated to patient engagement and patient empowerment. We have a lot of, our entire organization is around delivering healthcare, and yeah, we have a portal that needs to be improved, to put it mildly, and we have a patient care council that we meet with to explore other ways that we can make things better for patients. But I really think that a dedicated group that talks to people, when we want to know what's going on, we have a tendency to talk to ourselves, and I think we need to get out and talk to the patients, talk to the families, talk about what things are important to them, and how do we get them involved with a relationship with their health that we can support versus relationship to our healthcare system.
Right.
And I think the metamorphosis that's going to need to occur before we really improve that relationship beyond portals and newsletters and billboards.
Very good. Well, that's about all the time we had for today. When you close out your WebEx window, a survey is going to pop up of about 10 multiple choice questions. I don't think it'll take you more than a minute, and we would appreciate it if you answer the survey. Tell us how we're doing with these webinars and any areas we can improve. I want to thank our panel, Chuck Fennell, Dr. Howard Landa, and Blair Baker. I want to thank YourCareUniverse for sponsoring this event and allowing this conversation to take place. As I mentioned, you'll receive an email when our archive recording is up on our YouTube channel. Attending our events gets you CEU for the CHIME CHCIO certification. So if you have attended, let CHIME know you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox. Our final slide in our deck is a certificate of attendance if you need that for another program for your CEUs. And you can go to our website to see our upcoming schedule. So once again, I want to thank Chuck, Howard, Blair, and our audience, and everybody have a wonderful day. Thank you.